The trauma bay was too quiet for a night like this. Monitors hummed. Fluorescent lights flickered once, then steadied. A gurney rolled in fast, too fast, metal rattling against tile. Blood soaked through the sheets, dark and heavy. "Move aside," one of the surgeons snapped, brushing past the junior nurse without looking at her name tag. She stepped back. No protest. No reaction. Just watching. The patient on the table wasn't like the others. Even unconscious, his posture was rigid, controlled. His hands, cut, bruised, still looked trained. "Another transfer," someone muttered. "Stabilize and send up." They spoke over her, around her, ignored her. Then the man's eyes opened. Just for a second. Long enough to scan the room, and stop on her. Everything changed in that moment. But no one else noticed. Not yet. They still thought she was just the junior nurse. They were wrong. The hospital never truly slept, but there were hours when it seemed to hold its breath. Just past midnight, the trauma unit settled into that fragile stillness. Machines filled the silence with steady rhythms, monitors pulsing, ventilators exhaling, distant footsteps echoing across polished floors. The fluorescent lights hummed faintly overhead, washing everything in a pale, unforgiving glow. At the far end of the corridor, she stood at the nurses' station, reviewing charts. No one spoke to her. They passed by, close enough to brush her shoulder, but never quite seeing her. A junior nurse, still new enough that her presence felt temporary to the others. Her badge hung neatly, her uniform unwrinkled, her posture straight but unassuming. She didn't rush, didn't fidget, didn't try to fill the silence. Her pen moved steadily across the page as she updated notes, clean handwriting, precise spacing. Every detail accounted for. Every number double-checked. "Vitals stable," a voice called from across the station. She looked up. "Yes." "Heart rate normalized after." "Good," the surgeon cut in, already turning away. "Prep the next room." He didn't wait for her to finish. She nodded anyway. Understood. Her voice was calm, level. No irritation. No hesitation. She closed the file, placed it exactly where it belonged, and moved. The hallway lights flickered once as she passed beneath them. Most people didn't notice those things, the slight delay in illumination, the hum that changed pitch for half a second. But she did. Her eyes shifted upward briefly, registering it, then forward again. Room 3. Inside, a patient lay unconscious, oxygen mask secured, for lines running cleanly. The monitor displayed a steady rhythm, but something about the spacing between peaks wasn't quite right. She stepped closer, adjusted the angle of the sensor, waited. The rhythm corrected. A small change. Almost invisible. She noted it without comment and checked the flow. Slightly off. She recalibrated it, her fingers moving with quiet certainty, not rushed, not tentative. Behind her, 2 senior nurses entered. "Did you finish the prep in Bay 2? One asked. "Yes," she replied without turning. "Fluids are set, but the dosage may need adjustment if—" "We'll handle it," the other said, already moving past her. They didn't look at the chart she had just updated. Didn't ask what she had seen. She stepped aside, giving them space. Not retreating, just adjusting position, like she had already accounted for their movement before they made it. One of them glanced briefly at the monitor she had just corrected. She muttered. "Guess it fixed itself." The junior nurse said nothing. She stepped out of the room and continued down the corridor. At the end of the hall, a stretcher sat unattended for a moment, its wheel slightly misaligned. As she passed, she nudged it with her foot, correcting its angle so it wouldn't drift. Small things. Always small things. At the nurse's station again, a group of surgeons gathered, speaking in low but confident tones. Their conversation carried the weight of authority, decisions made quickly, conclusions drawn without hesitation. "She's still new," one of them said quietly, though not quietly enough. "Give it time." Another shrugged. "Or she'll move on." "They usually do." A brief pause. "Too quiet, anyway." They returned to their discussion. She didn't react. She picked up another chart, reviewed it, signed off. Across the room, a monitor emitted a sharp, irregular beep, just once, then returned to normal. Most of the staff ignored it. A glitch, nothing more. Her head turned instantly. Not alarmed. Focused. She watched the screen from a distance, her eyes narrowing slightly as she tracked the pattern. One irregular spike, then correction. It didn't match the patient's baseline. She walked toward the room, not hurried, but direct. Inside, the patient stirred faintly. She checked the electrodes. One was loose, barely. She secured it, then adjusted the patient's arm position by a few centimeters. The monitor stabilized fully. Again, no announcement. No need. As she stepped back, her gaze lingered, not on the patient, but on the door. The hallway beyond it. The reflections in the glass panel. Stillness. But not the same stillness as before. She stood there for a moment longer than necessary. Then she turned and left. Back at the station, the rhythm of the night resumed. Papers shuffled. Phones rang softly. Orders were given and followed. She moved through it all without friction. Invisible, but not absent. Every step measured. Every action deliberate. And beneath it all, beneath the routine, the dismissal, the quiet observations, something else remained. Not tension. Not fear. Control. The kind that didn't need to be seen. The kind that waited. The doors to the trauma bay slid open too fast. Cold night air followed them in, along with the sound of hurried boots and urgent voices cutting through the hospital's controlled rhythm. Incoming trauma, priority 1. The calm of the unit broke instantly. A stretcher was pushed inside, wheels rattling hard against the floor. Blood soaked through the lower half of the sheet, dark and uneven, already drying at the edges. One paramedic was still applying pressure to a bandage that had long since failed to hold. Unresponsive but breathing, someone called out. Multiple penetrating injuries. Possible blast exposure. The monitors in the hallway seemed louder now, as if reacting to the disruption. The junior nurse was already moving before anyone assigned her. No hesitation. Just positioning herself where she needed to be. The attending surgeon stepped in, scanning the patient once. "Get him stabilized," he said flatly. "We'll run imaging after." Routine words. Controlled tone. But the patient on the stretcher didn't fit routine. Even under sedation, his body resisted collapse. Muscles held tension where there should have been none. His posture wasn't fully surrendered to injury. It was controlled, trained, conditioned. The junior nurse noticed immediately. She didn't speak. She adjusted the 4-line angle as the stretcher passed her. A small correction. Barely visible. "Move," one of the senior nurses said, brushing past her shoulder. She stepped aside. The patient was transferred onto the bed. Metal rails clicked into place. Monitors were attached in sequence: ECG, oxygen, pressure. Beep, beep, beep. Irregular at first. Then stabilizing. "Vitals are unstable," someone said. "No," the junior nurse replied quietly, eyes fixed on the waveform. "They're compensating." The surgeon glanced at her. Not annoyed. Just dismissive. Compensating for what? She didn't answer immediately. Her gaze shifted to the patient's hands. Rough wounds. Deep lacerations. But the positioning, too precise. Defensive. Controlled spacing between injuries, as if not all damage came from the same source. "Secondary impact patterns," she said finally. "Not all of these are from the same event." The room went quiet for half a second. Then the surgeon exhaled. "Or he got unlucky twice," he said, already turning away. "Focus on stabilization." She nodded once. Understood. But she didn't move away. She adjusted the oxygen flow by a fraction. Not enough to draw attention. Enough to correct imbalance. The patient's breathing eased slightly. At the edge of the room, a crash cart was rolled in. A metal drawer slid open too loudly. Someone dropped a clamp. It hit the floor with a sharp echo that made no one flinch, but she tracked the sound longer than necessary. The patient's eyes flickered. Just a fraction of movement. Enough to notice. Not consciousness. Awareness. The surgeon leaned in. Pupils reactive. Barely, a nurse replied. The junior nurse stepped closer now. She didn't interrupt. She simply observed. The patient's left wrist twitched, subtle, controlled, reflexive suppression of pain response rather than uncontrolled spasm. That detail changed the way she looked at him. Not as a victim. As someone trained to endure. A radio crackled somewhere outside the room. Static. Then silence. Then nothing. One of the staff frowned. That's odd. No one responded. The surgeon began issuing instructions again, but his voice felt slightly further away now, as if the room itself had shifted focus. The junior nurse checked the 4 again. Flushed line. Adjusted pressure. She paused briefly at the patient's shoulder. A faint mark beneath the torn fabric. Not a hospital wound. Not accidental trauma. Something older. Something intentional. She didn't expose it. She simply noted it. And stepped back. At the doorway, 2 security officers passed by, speaking low. Transport clearance still pending. Higher command is involved. The words didn't register fully with the others in the room. But she heard them clearly. Her eyes followed them until they disappeared down the corridor. Then returned to the patient. The monitor beep steadied into a consistent rhythm. For now. But the room no longer felt like a routine intake. Something had entered the hospital with him. And it hadn't stopped moving. It was only waiting. The night settled again, but not into comfort. It settled into pressure. The trauma bay light stayed bright, too bright, as if refusing to acknowledge that anything had changed. The injured patient lay still now, stabilized on paper, but not truly at rest. Machines confirmed life. Numbers confirmed stability. But the room itself suggested otherwise. The junior nurse remained at the edge of the bed. Not obstructing. Not intervening. Just observing. The attending surgeon reviewed the chart at the foot of the bed. Pressures holding. We'll move him to ICU once imaging clears. Routine conclusion. Clean closure. But the nurse's eyes didn't leave the patient. His breathing pattern had changed again. Not worse. Not better. Controlled. There was a rhythm to it now, subtle pauses between inhalations that didn't match sedation curves. She adjusted the oxygen mask strap without comment. A fraction tighter. A fraction more precise. The monitor stabilized again. One of the senior nurses glanced at her. You keep adjusting that. It's fine. It wasn't, she replied calmly. No challenge in her tone. Just certainty. The nurse frowned but didn't respond. Across the room, a doctor flipped through imaging orders. Any ID on him yet? Nothing civilian, someone answered. No wallet. No phone. No tags. That should have ended the conversation. It didn't. Because absence of identity always created space for speculation, and speculation always created unease. The junior nurse's gaze moved to the patient's forearm. Bruising pattern. Not random. Linear restraint marks, faint but visible beneath the swelling. Old injuries layered beneath new trauma. She stepped closer. Checked capillary refill. Then pulse symmetry. Her fingers paused for half a second longer than necessary at the wrist. Not because she hesitated. Because she confirmed something. Multiple restraint exposures, she said quietly. The surgeon didn't look up. Could be from transport. No, she said. Still calm. Still controlled. Repeated prior restraint. Not recent. Silence followed. A few staff exchanged glances. Not disagreement. Dismissal. We'll note it, the surgeon said finally, already turning back to his notes. But she noticed something else. The patient's fingers had shifted. Barely. A micro-adjustment in hand position. A trained repositioning even under sedation. Not reflex. Recognition. She didn't react outwardly. But internally, the pattern became clearer. This wasn't a civilian trauma case. This was someone trained to remain aware while incapacitated. Someone conditioned to track surroundings even in compromised states. A soft beep interrupted her thoughts. The monitor spiked. Once. Then corrected. A nurse leaned in. Artifact. Likely, someone replied. But the junior nurse had already moved closer to the screen. She replayed the waveform in her mind. That spike wasn't random. It aligned with a faint movement in the patient's eye, barely perceptible beneath the eyelid. She leaned in slightly. Pupillary response again, she said. The resident checked. Still sluggish. But she didn't agree. Not fully. Something was happening beneath sedation. Awareness wasn't absent. It was contained. Outside the room, footsteps passed quickly. Then more. Then a pause. 2 security staff stopped briefly at the glass panel, speaking in low tones. One pointed toward the room. The other shook his head. They moved on. The junior nurse watched them go. Then returned her attention to the patient. The mark beneath his collarbone, partially visible now, caught the light differently as he shifted slightly. She didn't ask for permission. She gently adjusted the sheet. Just enough to see. A faint, old surgical scar. Not hospital standard. Not recent trauma care. Her expression didn't change. But her mind organized the information instantly. Old field procedure. Controlled environment. High-level extraction history. The surgeon's voice cut through again. We'll run full imaging in ICU. For now, keep him stable. The team began to disperse. The urgency faded. Routine reasserting itself. But she didn't leave. She stayed until the room quieted. Until only monitors remained. Until only breathing remained. Then she adjusted the 4-drip one final time. Not correcting. Refining. The patient's breathing steadied into a deeper rhythm. And for a brief moment, just a fraction of a second, his fingers shifted again. Not toward panic. Not toward pain. Toward awareness. She met that possibility without reaction. No words passed. No acknowledgement was made. But something in the room had changed. Not visibly. Not loudly. Just enough to remain. And just enough to wait. The transfer to ICU never came on time. Delays in a hospital were common, but this one carried a different weight. Quiet, procedural, almost invisible on paper. Orders were still valid. Approvals still pending. But the movement of the patient had stalled in a way that didn't match urgency. The junior nurse noticed first. Not through announcements. Through absence. The corridor outside the trauma bay had changed rhythm. Fewer footsteps. Slower response times. Doors that should have opened immediately now paused before unlocking. She stood at the nurse's station, reviewing the updated chart. No one else commented. Inside the trauma bay, the patient remained stable. Machines confirmed it. Monitors insisted on it. But stability, she knew, was not the same as safety. A security officer passed the glass window again. Then again. This time stopping longer. Watching. The attending surgeon noticed him too. Why is security circling? No one answered immediately. A second officer appeared at the far end of the corridor. Then another. They weren't rushing. They were positioning. The junior nurse's gaze lifted briefly. She said nothing. But she recorded everything internally. Then a radio crackled. Not in the room. Somewhere deeper in the hospital. Static first. Then a clipped voice. Confirm patient location. A pause. Then, do not proceed with transfer until clearance is verified. The surgeon frowned. Who's overriding ICU transport? No answer came. Only silence. And then movement outside the glass increased. Not panic. Coordination. The atmosphere shifted in a way that was difficult to name. Not loud enough to be an emergency. Not calm enough to be routine. The junior nurse stepped slightly closer to the bed. The patient's breathing was steady. Too steady. Controlled sedation responses rarely held this consistency under delayed transfer stress. Something about his physiology resisted destabilization. She checked the 4-line again. Flow correct. Dosage correct. Yet still. His body held tension beneath stillness. As if waiting. One of the residents entered quickly. We've got an issue with clearance. Admin says. He stopped mid-sentence. because two more security personnel entered behind him. Not hospital security. Different posture. Different presence. They didn't speak to the staff. They scanned the room first. Then the patient. The air tightened. The surgeon straightened slightly. "Can I help you?" One of the officers held up a hand. Not aggressive. Restraining. "Standard verification," he said. But his eyes never left the patient. The junior nurse stepped half a pace to the side, not blocking, not retreating. Just adjusting position so she could see both the officers and the monitor simultaneously. A habit. Or something more precise than habit. The monitor beeped once. Irregular. Then corrected. The officer noticed it. So did she. A microchange in heart rhythm. Triggered. Not random. External stimulus response. She glanced toward the hallway. Footsteps outside had stopped. Entirely. The hospital felt suddenly contained. Like a sealed room. The second officer spoke quietly into a radio. Visual confirmed. Holding position. The surgeon lowered his voice. "What exactly is going on?" No one answered him directly. But the junior nurse understood something was forming. Not a medical complication. Not a procedural delay. Containment. She looked at the patient's hand. Fingers slightly curled now. Not relaxed. Prepared. Then a distant sound echoed through the corridor. Helicopter rotors. Faint at first. Then growing. The surgeon turned sharply toward the window. "Why is there air support?" He stopped. Because now everyone could hear it. The sound wasn't landing randomly. It was approaching with intent. The security officers shifted immediately. Subtle repositioning. Doorway coverage. Line of sight control. The junior nurse didn't react outwardly. But her eyes narrowed slightly. Not at the noise. At the coordination. This was not hospital escalation. This was external confirmation. Arrival of authority. The patient's eyelids moved again. Barely open. Just enough. The monitor spiked once more. Then stabilized. The helicopter sound grew louder. Closer. And in that moment, the room stopped being a medical space. It became a point of contact. Between systems. Between identities. Between something hidden and something arriving to confirm it. The junior nurse placed her hand lightly on the edge of the bed rail. Still. Controlled. Waiting. Because whatever was coming was not coming for the hospital. It was coming for him. The helicopter never landed on the hospital roof. It hovered just long enough to make its presence known. Then it moved away, circling, waiting, coordinating. But the damage was already done. The hospital had changed posture. Security checkpoints were no longer casual. Doors that once opened freely now required verification codes that didn't exist an hour ago. Staff moved faster, but less confidently. Even conversations had shortened, as if words themselves were now a risk. Inside the ICU holding bay, the injured patient remained under watch. But the room no longer felt like it belonged to the hospital. The junior nurse noticed it immediately. Not because anyone told her. Because everything had become layered with intention. Two security officers now stood outside the door. Not casually positioned, tactically placed. One watching the corridor, one watching the room. The attending surgeon stepped in, visibly irritated. "I want a direct answer. Why is external security involved in a trauma admission?" No response came. The officers didn't acknowledge him. Their attention stayed on the patient. The junior nurse adjusted the foreline without being asked. Small correction. Flow stabilized. The monitor responded instantly. One of the officers noticed that. His gaze shifted to her for the first time. Not suspicion. Assessment. She didn't look back. She simply stepped half a pace to the left, improving her angle on both the patient and the corridor beyond the glass. A subtle reposition. But deliberate. Inside the room, the patient's breathing pattern changed again. Not worse. More controlled. Like awareness returning in fragments. The surgeon leaned over the chart. Sedation levels are consistent. There's no medical reason for fluctuation. There is, the junior nurse said quietly. Everyone paused. Even the air seemed to slow. The surgeon turned slightly. And what would that be? She didn't answer immediately. Instead, she checked the patient's pupils again. Then the wrist monitor. Then the oxygen waveform. Only after confirming did she speak. External stimulation response, she said. A pause. That's not possible under current sedation, the resident replied. It is, she said calmly, if the nervous system is trained to override it. Silence followed. Not disbelief. Discomfort. Because that statement didn't belong in routine trauma care. The security officer outside the door shifted his stance slightly. Not reacting. Confirming. The second officer spoke quietly into his radio again. Condition unchanged. Monitoring continues. The junior nurse stepped closer to the bed. Not urgently. Not hesitantly. Precisely. She adjusted the patient's head angle by a few degrees. Not for comfort. For airway alignment under potential movement. The monitor stabilized further. Then something changed. A sound in the corridor. Not loud, but intentional. Boots. Measured. Not hospital staff. The officers outside the room stiffened slightly. The door remained closed. But everyone in the room felt it. Arrival. The surgeon lowered his voice. Who is that? No one answered. The footsteps stopped directly outside the ICU door. A pause. Then a single knock. Controlled. Not impatient. Commanding without force. The junior nurse did not move. But her attention sharpened. The patient's fingers curled once more. Then stopped. The monitor registered a minor spike in heart rate. Not instability. Recognition. The door opened. A man in uniform entered first. Not a doctor, not hospital security. His posture alone changed the room dynamics. He didn't speak. He looked at the patient. Then at the officers. Then finally, briefly, at the junior nurse. That glance lasted less than a second. But it carried confirmation. The security officers stepped aside immediately. Not ordered. Acknowledged. The surgeon frowned. You can't just... He stopped. Because another figure entered behind the uniformed man. Wounded. Supported. Breathing controlled but strained. A Delta commander. Even injured, his presence reshaped the room. He didn't look at the surgeons. Didn't look at the monitors. His eyes went directly to the bed. And then, slightly to the side. To her. The junior nurse. The room did not move. Not a sound. Not a machine. Even the monitors seemed less dominant. The commander raised 2 fingers weakly, not a salute in full form, but something restrained, deliberate. Acknowledgement. Quiet. Intentional. The surgeon's voice disappeared entirely. The resident froze. Even security stopped moving. The commander exhaled slowly. Still looking at her. Not speaking. But confirming something that did not need translation. The junior nurse did not react outwardly. No nod. No change in expression. She simply held her position at the bedside. Steady. Controlled. As if this moment had already been accounted for long before anyone else entered the room. The room remained frozen in that state. Not chaos. Not resolution. Something in between. Then the commander looked away. And the world slowly started moving again. But differently than before. Because control had shifted. And no one in the room could pretend otherwise anymore. The acknowledgement did not end the situation. It deepened it. After the Delta commander was moved to stabilization, the ICU did not return to normal rhythm. Instead, it entered a controlled tension, like a system running under restricted authority. Every movement now carried awareness of oversight beyond the hospital. Security presence increased within minutes. Not loudly. Not chaotically. Systematically. New personnel rotated in. Doors were recoded. Access logs were manually verified instead of automated. Even the air in the corridors felt heavier, as if the building itself had become an active operational site. The junior nurse continued her work. Unchanged. That was what made her presence harder to read. She did not react to the increase in security, did not question the hierarchy shifts, did not look for explanations. She simply adjusted to the new structure as if it had already been anticipated. Inside ICU Bay 2, the original patient remained under monitoring. Still sedated. Still stable. But not untouched. Something about the room's energy had changed after the commander's brief acknowledgement. Not medically measurable. Operationally significant. The surgeon stood near the glass partition, speaking low. "We need clarification. Who authorized military-level oversight in a civilian trauma case?" No one answered, because now even hospital administration seemed uncertain. Outside the unit, movement increased again. Faster this time. More direct. The junior nurse noticed it before anyone spoke. Footsteps that didn't belong to rotating staff. They had direction. Purpose. She stepped slightly closer to the patient's monitor. Heart rate unchanged. But respiration pattern tightened. Not medically unstable. Behaviorally responsive. She glanced toward the corridor reflection in the glass. 3 new figures approached. Not hospital personnel. Not standard security. Their presence altered the space before they even entered it. One of the officers already inside the ICU shifted his stance. "We're holding protocol until confirmation." The lead figure stopped outside the door. No response. Just a pause. Then the door opened. This time without delay. The atmosphere in the room tightened instantly. The surgeon straightened. This is a restricted medical environment. No acknowledgement. The lead figure stepped inside. He scanned the room in a single controlled motion. Then spoke. "Status of asset." The word landed incorrectly in a hospital space. Not patient. Not casualty. Asset. The surgeon frowned. "Excuse me." The security officer beside the bed didn't move. The junior nurse did not react to the wording. But she noted it. Precisely. The second figure entered behind the lead, carrying a compact case. Medical grade but not hospital issued. The third remained at the door. Blocking. Not aggressively. Functionally. The lead figure's gaze settled briefly on the monitor. Then the 4-line. Then the patient. Finally, on her. Just as before, the glance lasted less than a second. But it contained confirmation of something already known. The surgeon stepped forward. "If you're here for consultation, you need to coordinate through hospital command." The lead figure didn't look at him. "We are already past that stage," he said. Silence followed. The junior nurse adjusted the 4-drip slightly. Flow correction. Minimal. The monitor responded instantly. The second figure opened the case. Inside were compact diagnostic tools, field-capable, not hospital standard. No one stopped him, because no one fully understood who had authority in the room anymore. The patient's fingers moved again. This time more noticeably. Not random. Controlled micro-movement. A signal response pattern. The junior nurse stepped half a pace closer. Not interfering. Just aligning herself with the patient's shoulder line. The lead figure noticed that shift. So did the others. But none commented. Outside the room, alarms did not sound. But systems began rerouting silently. Communication channels restructured. Hospital authority paths bypassed. The ICU was no longer operating under standard governance. It was being observed, evaluated, and quietly integrated into something larger. The patient's breathing deepened. The monitor registered a slight elevation in heart rate. Not instability. Recognition threshold. The junior nurse did not move her hand from the bedside rail. But her focus sharpened further. The lead figure spoke again, quieter this time. "He's waking patterning." No one responded. Because it wasn't a question. It was confirmation. The room held that state for several seconds. Then the patient's eyelids moved. Not fully opening. But enough. Enough for awareness to surface. Enough for the system around him to register change. The junior nurse did not step back. Did not step forward. She simply remained exactly where she was, as if she had already accounted for this moment long before anyone else entered the room. And now, everything was beginning to converge. The ICU no longer felt like a place for treatment. It felt like a controlled perimeter. Every movement in the corridor had structure now. Measured steps, verified access, silent communication between personnel who did not need to speak aloud. Even the hospital staff who remained inside the unit worked differently, as if adapting to rules they had not been given. The junior nurse stayed at the bedside. Still, focused. The patient's condition had shifted again. Not deterioration. Not improvement. Transition. His breathing was no longer purely mechanical support. It carried intermittent self-regulation beneath sedation. Small, controlled recoveries of awareness. The lead figure stood near the foot of the bed, observing. The surgeon had stopped arguing. That had happened some time earlier, without a clear moment marking the change. Resistance simply ran out of place to stand. Outside the glass, security maintained position. No one was moving randomly anymore. Everything had purpose. The junior nurse checked the foreline again. Flow correct. Sedation stable. But she adjusted it anyway. A fractional change. Not to increase or decrease effect. To balance response timing. The monitor reacted instantly. The patient's fingers curled once. Then relaxed. The second figure from the field team glanced at the waveform. He's responding faster than expected. Not faster, the junior nurse said quietly. All eyes turned slightly toward her. She did not look up. More controlled, she corrected. Silence followed. The surgeon finally spoke, lower than before. If you know something about his condition, it needs to be documented. She paused for a moment, then answered. It already is. No further explanation. Because none was needed. The lead figure stepped closer to the monitor. You're modifying stabilization parameters without directive? Her gaze remained on the patient. Yes. No hesitation. No justification. Just confirmation. A long silence followed. Not tension in the usual sense. Decision weight. The kind that forms when authority stops being abstract and becomes present in the same room. The surgeon looked between them. You're not cleared to. The lead figure raised a hand slightly. Not to silence him aggressively, but to stop the conversation from branching in the wrong direction. It is already under jurisdiction transfer, he said calmly. The room shifted again. Not physically. Structurally. The surgeon stepped back slightly. The junior nurse did not move. But something inside her posture changed. Not defensiveness. Alignment. The patient's breathing deepened. A subtle increase in voluntary control surfacing under sedation layers. The monitor registered it immediately. The second figure spoke quietly. He's stabilizing toward awareness threshold. The lead figure nodded once. Then we proceed carefully. That word, proceed, carried weight beyond medicine. The junior nurse understood that. So did the patient. Because his fingers moved again. This time not reflexively. Deliberately. A signal pattern emerging through suppression. The room held still. Then, a faint sound outside the ICU. Not alarms. Not chaos. Just movement increasing at corridor intersections. The junior nurse turned her head slightly toward the glass. She saw it before it was announced. Hospital access points shifting again. But this time not inward. Outward containment. The realization formed quietly. Whatever was happening was no longer just about arrival. It was about control boundaries. The choice was no longer clinical. It was operational. The lead figure looked at her directly now. Not evaluating her competence, but acknowledging her position within the current structure. You have two options, he said quietly. The room did not react outwardly. But everything became still enough to hear the weight of it. She did not respond immediately. She adjusted the oxygen line once. Checked the monitor. Then looked at the patient. His eyes were not fully open. But they were present. Aware enough. Waiting enough. She understood the implication without needing clarification. Continue operating within hospital protocol, or transition into what this situation already had become. She exhaled slowly. Not a sign of stress. A measured decision point. Then she spoke. Keep him stable through transition window. Not refusal. Not acceptance. Alignment. But on her terms of precision. The lead figure studied her for a moment, then nodded once. The second figure resumed preparation of the field equipment. Security outside adjusted positions again. The surgeon said nothing further, because at this point, words had stopped being useful inside the room. The patient's fingers curled once more. Slightly stronger this time. Not panic. Recognition. And the junior nurse remained exactly where she was, at the center of a system that had quietly shifted around her, holding the only thing that still mattered in that moment. Continuity. The ICU lights felt different now. Not brighter. Not dimmer. Heavier. As if the room had been quietly sealed from the rest of the hospital, leaving only what was necessary inside it. Even the distant corridor noise seemed filtered, reduced to a low, indistinct presence beyond glass and concrete. The patient remained on the bed, stabilized, but no longer fully passive. There was awareness now. Not complete consciousness, but fragments. Controlled return of perception. The junior nurse stayed at the bedside, her posture unchanged from the beginning of the shift. Calm hands. Minimal movement. Eyes that tracked everything without appearing to track anything at all. The field team had adjusted their positions slightly. Not crowding. Not withdrawing. Rebalancing. The lead figure stood at the foot of the bed again, watching the monitor. The surgeon had stopped asking questions entirely. He now observed in silence, as if participation had shifted into observation without instruction. Outside the glass, security remained steady. No urgency. Just containment. The second field operator adjusted a compact diagnostic unit. Soft electronic tones replaced the hospital's usual sterile beeps. The patient's breathing deepened again. A subtle shift. Voluntary control increasing beneath sedation. The monitor registered it immediately. The junior nurse leaned in slightly, checking airway alignment. No unnecessary adjustments. Only confirmation. Then it happened. The patient's eyes opened. Not fully. Not sharply. But enough to see. Enough to register the room. His gaze moved slowly, controlled, even in weakness. First the monitor. Then the field team. Then the security at the glass. And finally, it stopped. On her. The room did not react outwardly. But something inside it tightened. Not tension. Recognition. The patient's focus held. Not confusion. Not surprise. Confirmation. The lead figure noticed the shift immediately. So did the second operator. But neither interrupted. The surgeon took a half-step forward, then stopped himself. Because this was no longer a medical threshold. It was something else. The patient's lips parted slightly. No full speech. Just breath shaped into intent. The junior nurse did not move. Did not step closer. Did not step back. She simply met the moment without breaking form. A long pause followed. Then the patient lifted his right hand slightly from the sheet. Weak. Controlled. But deliberate. The movement was not random. It was structured. And it ended in a gesture that did not belong to hospital language. Not dramatic. Not ceremonial. Precise. A restrained acknowledgement. The room did not speak. No one interrupted it. The gesture held for only a moment. Then the hand lowered again. The patient's breathing steadied afterward, as if the effort itself had been measured and completed. The junior nurse adjusted the oxygen line by a fraction. Not as response. As continuation of care. But something had changed. The lead figure spoke quietly, almost to himself. Confirmed. No elaboration. No explanation needed. The second operator closed the diagnostic case. The security outside subtly shifted stance again, but not toward escalation. Toward resolution. The surgeon looked at the junior nurse for the first time without dismissal. Not curiosity. Not authority. Something closer to reassessment. But he still said nothing, because there was nothing left to say that would hold weight in this space. The patient's eyes remained open now, not fully alert, but present. He was no longer drifting. He was observing, and the observation was directed, not at the room, not at the system, at her. The junior nurse finally looked down slightly, not breaking composure, but acknowledging the patient's state. A quiet exchange formed in the silence. No words, no signals from anyone else. Just recognition passing between 2 points that understood the same structure beneath the situation. After several seconds, the patient's gaze softened, not weakening, settling, as if confirming what needed confirmation. Then his eyes slowly closed again. Not collapse. Rest. Controlled withdrawal. The monitor stabilized into a steady rhythm. The field team stepped back slightly. The lead figure gave a single, subtle nod. And the room exhaled, collectively, silently. But nothing returned to what it had been before. Because acknowledgement had already happened. And once it happens at that level, it does not reverse. It only settles deeper. The junior nurse remained at the bedside. Still, unchanged, but now no longer unseen. The hospital did not return to normal. It adapted, quietly, without announcement or acknowledgement. Protocols shifted in ways most staff would never fully notice. Access logs rewritten, ICU routing redefined, external communication filtered through channels that did not previously exist in the hospital structure. Inside ICU Bay 2, the patient remained stable. Sedation now carefully balanced, not to suppress, but to maintain controlled rest. The field team had withdrawn from immediate bedside dominance, repositioning to the perimeter. Their presence was no longer intervention-driven. It was oversight. The junior nurse continued her duties without interruption. Charting, monitoring, adjusting only what required adjustment. No excess movement. No wasted action. The surgeon stood near the glass partition, hands lowered, expression restrained. He was no longer questioning what he was seeing. He was documenting it internally, trying to align experience with frameworks that no longer fully applied. Outside the unit, security rotations stabilized. No new arrivals. No visible escalation. But containment had been established. Not of a threat inside the hospital, but of information flow around it. The junior nurse checked the 4-line once more. Flow steady. Vitals controlled. Patient response consistent. She made no additional adjustments. None were needed. The lead field figure entered briefly, this time without entourage. He stopped near the monitor, reviewed the readings, then looked at her. No extended inspection this time. Just confirmation. Stabilization held, he said. She replied simply, yes. No elaboration. None required. He nodded once and stepped out again. The room returned to controlled quiet. But the silence now carried structure. Not uncertainty. Containment. Minutes passed. Then more. The patient remained unconscious, but no longer unstable in any sense. His body had settled into a recovery state that no longer required constant correction. Still, the junior nurse did not leave her position. Not because she was instructed to stay, but because her role within this moment had not concluded. The surgeon finally spoke, voice low. What happens now? No one answered immediately, because the answer did not belong to hospital hierarchy anymore. It belonged to whatever system had entered the space earlier, and confirmed itself through acknowledgement. The junior nurse continued watching the monitor, then spoke quietly. He recovers under observation. That was all. No speculation. No expansion. Just fact. The surgeon looked at her for a long moment, then looked away. Outside the glass, movement resumed in the corridor, but not urgency. Staff returning to duty cycles. Normal hospital rhythm attempting to reassert itself over something it did not fully understand. But the ICU remained unchanged, sealed in its own equilibrium. The patient's breathing deepened slightly. Stable. Controlled. Resting. The junior nurse adjusted nothing. She simply observed the final stabilization curve. Then, after a long pause, she stepped back from the bedside for the first time in hours. Not leaving. Not withdrawing. Repositioning. The room no longer required intervention. Only continuity. The field presence had done its work. The hospital would resume its routines. Reports would be written in incomplete language. Explanations would be fragmented. But the core event would remain undocumented in full clarity. Because some parts of control do not translate into records. They only exist in what people stop questioning afterward. The junior nurse removed her gloves slowly, disposed of them, cleaned her hands, then returned to the charting station. The monitor continued its steady rhythm behind her. The patient remained stable. The system remained intact. And the moment had passed without ever becoming visible in full. Only understood. Quietly. At the edges, morning arrived without announcement. No dramatic change in lighting. No sudden relief. Just a gradual shift in the hospital's atmosphere as night duty gave way to day staff, and the controlled tension of the ICU softened into routine clinical rhythm again. But nothing was fully routine anymore. Not for those who had been in ICU Bay 2 during the night. Inside the unit, the patient remained stable. Vital signs consistent. Sedation reduced to maintenance levels. Recovery trajectory steady, monitored, and now handed back into standard critical care protocol. The field team was gone. No visible trace remained of their presence except for subtle administrative adjustments that most staff would never question. The surgeon reviewed the updated chart once, then closed it without comment. He did not revisit earlier conclusions. Some cases, he understood now, did not fit within traditional classification long enough to be explained in real time. They only resolved into understanding afterward. The junior nurse stood at the end of the bay, preparing to finish her shift. Her movements were the same as always. Measured. Quiet. Unremarkable to anyone who had not been paying attention the night before. One by one, staff began to disperse. Conversations resumed in low tones about routine cases, staffing, schedules. The ICU slowly reattached itself to the hospital's normal identity. But not entirely. Because memory remained, even when unspoken. The patient turned his head slightly during a brief moment of wakefulness. Not enough to fully open his eyes. But enough. The junior nurse noticed immediately. She did not approach. She simply paused what she was doing. The room held still for a second longer than necessary. Then his eyes opened briefly. This time there was no monitoring response, no external intervention, no field presence. Just two people in a controlled environment. No acknowledgement from the staff nearby. No disruption in routine. Only a brief, quiet exchange that did not require interpretation. The patient looked at her. Not searching. Not confirming. Just recognizing. Then, slowly, he closed his eyes again. Rest resumed. The junior nurse adjusted nothing. There was nothing left to correct. A few minutes later, a transport team arrived to move him to long-term critical recovery. Standard procedure. No priority markings now. No external oversight visible. Just hospital care continuing its path forward. As the gurney was prepared, one of the staff glanced at her. "You've been on since last night?" they asked. "Yes," she replied. A pause. "That's a long shift." She nodded slightly. "It's over now." No further conversation followed. The patient was moved out of ICU Bay 2. Wheels rolling softly across polished floors. Monitors disconnecting one by one. The sound of controlled continuity replacing controlled crisis. The junior nurse watched until the corridor turned empty. Then she returned to the station. Signed off her charting. Cleaned her workspace. No one stopped her. No one asked questions that would not be answered in standard language. At the exit corridor, she removed her ID badge, as required at shift end. Held it for a moment. Then clipped it back in place. The hospital continued behind her. Unaware of how much had shifted within its structure during the night, and how little of it would ever be officially recognized. Outside, daylight was ordinary. Cars moved. People spoke. Life continued in its predictable form. She stepped out of the hospital without looking back. No recognition followed her. No explanation remained behind her. Only a quiet understanding embedded in the space she had occupied. And somewhere inside the hospital, a chart updated itself into permanence. Stable. Recovering. Case closed in appearance, but never fully in understanding. The junior nurse walked forward into the morning, not as someone who had changed the system, but as someone who had never needed it to recognize her in the first place. And the hospital continued as if nothing had happened at all.